Welcome to Ask the Educator, a podcast brought to you by Healthmark Industries. Are you a sterile processing technician or manager? Maybe you work in infection prevention or biomedical engineering. Whether you're a frontline tech, endoscopy tech, OR nurse, or surgical services administrator, you undoubtedly have influence in medical device processing at your facility. In each episode, we speak with experts from the Healthmark Clinical Affairs team, industry leaders, or special guests from the trenches to answer your questions and bring you relevant industry information, equipping you for excellence in medical device processing. My name is Kevin Anderson, and I will be your host. Now let's get started. Hello, everyone, and thank you for listening to the podcast. This is Kevin Anderson, your host, and in this episode, I wanted to pick up with our Survey Readiness series. However, this time I wanted to turn our focus to endoscopy. And for this reason, I asked my colleague, John Whelan, to join me. So, John, thanks again for joining me on the podcast. Welcome back.
Thanks, Kevin. Happy to be here.
All right. So let's get right into it. Talking about endoscopy and survey readiness. So how do accreditation surveyors approach endoscope processing?
So as you know, I know, Kevin, it's not uncommon that one of the first series of questions they ask when they walk into a facility is, tell me what departments reprocess reusable devices, tell me where the endoscopes are, tell me who reprocesses endoscopes. And they then also ask for the policies related to endoscope processing. So when they actually survey, they're surveying to your policy, they're surveying to the manufacturer's instructions for use. And citations arise when you're not following your own policy and you're not following the manufacturer's instructions for use.
Yeah, that's absolutely correct. And I remember thinking about this as we had the education arm, if you will, of the Joint Commission in, and you know, they'd find little things like following the little test strips of the detergents, IFU and all that, or they'd find one with that's been expired, something like that. Low hanging fruit, right? But
exactly.
It's so frustrating when they do, but that's the kind of stuff that they find. And they look at the credentials of the people who are cleaning the scopes. But what exactly are expected endoscope cleaning and disinfection sterilization practices based on?
Yep. So this is pretty obvious. They're based on the distinct steps of processing. So as long as all our energies in the day-to-day work that we do, as well as preparing for a survey, focus on the steps for processing, that's the appropriate focus that we need to have. So everything from point of care treatment, pre-cleaning, all the way through processing back to storage and reuse. It's each of the steps of processing that they're going to follow. Again, comparing it against your own policies as well as the IFUs.
Excellent. So one of the things that I remember we focused on while I was still working in the hospital, we were kind of moving as a whole health system, trying to work on this drying of endoscopes. So It has gained increasing attention over the last several years. So how are surveyors looking at this particular step of the process?
So, as you know, and others in the audience know, surveyors over the last several years have been pointedly taught what to look for when it comes to endoscopes, endoscope processing. And they're also at the table when it comes to standards development as well, giving input, getting input. And when it comes to drying, they're very much paying attention to the clinical investigations, the research that has occurred, especially over the last, I would say, 5 to 8 years related to drying of endoscopes. And it's become very clear that endoscopes in storage are still wet. Anyone that's removed an endoscope from an AER knows that it's still dripping. You hold it vertically and water drips out the distal tip. The outside of the scope is still wet. And the focus is shifting to active drying of the endoscope. So similar to everything else, they're going to be paying attention to what does the manufacturer say to do as far as drying of the endoscope manufacturer. And then if you're using any automated processes, they're going to see that those match and you're following those steps appropriately. So where things are shifting when it comes to standards and guidelines, and that's what the surveyors are basing their attention on, is active filtered forced air drying of endoscopes, either before they move into storage or as they're in storage, active drying during storage.
Yeah, I've definitely seen that as well. And one thing I think that's important too is, I guess, to differentiate drying as almost two different components. You have the external surface,
Yep.
and the internal surface. And I think one of the things that has come out over time is especially those channels, right? Because even after, say, the dripping of the scope is done, long after, haven't they also found that the inside of the channels are often still containing moisture, even though the scope may have air dried on the external surface?
Yes.
Yeah.
And as we know, there's multiple different versions of endoscope storage cabinets now. Historically, I mean, they've run the gamut from converted utility closets to true endoscope storage cabinets, and minimally they should have filtered forced air blowing into the cabinet. Things are moving away from having passive air, just having vents, if you will, on the front or the back of the cabinet to let air passively flow. Now the focus is on having filtered forced air flowing through the cabinet. But again, like you said, that predominantly takes care of the exterior of the scope, but the scope should still be manually dried before it's hung in the cabinet. And then, as you pointed out, the channels, research has shown that for days, even weeks later, moisture still exists within the channels of endoscopes. And why we're talking about all this, if moisture is retained, then that's obviously opportunity for microbial contamination and or biofilm development.
Which is exactly the reason why drying has been such a high point on the radar, I think, of surveyors, but also just systems trying to solve this problem.
Yep. Let me just add to a lot of people, when it comes to drying, they're thinking we don't have a ton of money to spend on getting fancy new cabinets and retrofitting our department. Well, the good news is there's multiple options. Again, there's converting your existing endoscope cabinet to having filtered forced air blowing into the cabinet. There's also actual drying cabinets that have tubing that hooks up to the channels and actively dry. But then there's also tabletop dryers that you can use before a scope goes into storage. And we also have means now for checking to see if a scope is dry, a scope channel is dry after it's been in storage. So there's multiple options for instituting drying, as well as double checking to see if drying is sufficient.
Exactly. I think to your point, there's just a lot of options now for people to implement a drying procedure that weren't there just a couple of years ago. And then to be able to check your procedure to make sure your endoscope is dry. That's a whole nother layer that is awesome to have at your disposal. I think before we thought, we'll flush the channel with an alcohol purge and an air purge and hang it up and we're good to go.
Yeah. Yeah, the misconception for years has been, well, the AER does that. Well, what the AER does, it's a purge. It's not a drying cycle. It's not meant to be a drying cycle for the channel. Again, you pull a scope out of an AER, it's still wet on the outside and it's still wet on the inside. So
exactly,
you have to do something actively after it comes out of an AER. And the way the standards and guidelines are moving, it doesn't matter if that scope's headed right to another procedure or into a storage cabinet. You do the same thing.
That was my question.
Yep.
That was my question right there. You just answered it, is because this is one that comes up in those very busy endoscopy units. Hey, does it matter if my scope is wet after processing, if it's just going right back into an endoscopy suite and being used on a patient?
As with so many other things in processing, Kevin, we need to have things that are consistent and sustainable, regardless of what's happening downstream. So what happens if the procedure is canceled? What happens if the procedure is delayed? It only takes minutes for biofilm to form. So yeah, you can't guarantee that just because you think you're going to use it in the next procedure that it's going to happen. But it runs the gamut from one facility to the next as far as where the processing area is, what department's processing the scopes, routing them back to endoscope processing areas. So before the scope ever leaves the processing area, you want to sign off that you've done everything you're supposed to do, and that includes drying it before it leaves. the area.
I agree completely. And this was exactly the issue we were dealing with before I left my former facility. And I know there are a lot of places out there who would just like, they're probably cringing inside thinking about trying to add another 10 or 15 minutes, whatever it takes to every endoscope. Maybe they just can't afford that time. Well, unfortunately, whether you can afford it or not, this is the time to leverage these standards and guidelines, this best practice in order to get the resources you need. Obviously, your endoscope inventory isn't meeting the need.
Yep.
So,
and also, I think this is a good opportunity to engage infection prevention and accreditation within your facility to help be your advocates for what you need, and also to help run interference as needed with clinicians. When you have those sit-down discussions, granted, it's treated like an assembly line, obviously processing, and yet this is more than an assembly line. This is the next patient in line that we're focused on. So we need to make sure that every step is managed appropriately. And because we may be adding a couple minutes or 10 minutes to processing, it's the right thing to do.
Exactly. It's the right thing to do. Like John said, utilize those resources in your health systems, your quality department, your infection control. They're some of your best advocates. I know they were in my former facility, so reach out to them if you're in need there. But kind of moving on to some more general things regarding endo, what are some of the common system level weak points and risks that you've been seeing?
Yeah, so it's not uncommon for any process in life to manage when there's multiples. So when you have multiple staff, when you have multiple ways of doing things, you have multiple types of scopes, you have multiple chemistries, you have multiple processing methods, it all makes it risk prone. So whatever can be done to standardize and simplify so that within a health system, there's a standard way of doing things regardless of the department that's processing the scope. So think about the not uncommon at all scenario that has existed for years in a clinic setting. We're processing scopes. So an MA, medical assistant, or a tech was hired. They were trained in their programs to room patients, assist caregivers, provide supporting services. But then once they're out in the real world, they're also being asked to add device processing on top of all that. And they never received any kind of formal training for device processing. Think about the coincidental demands that are made on them too. The very real possibility that because of those coincidental demands that shortcuts may intentionally or unintentionally be made too. So if they're being pushed to bring the next patient back in, or to provide immunizations or whatever their multiple tasks are, something's got to give. And not uncommonly, it's processing. So also another example is think of the clinic nurse serving as backup to processing. That's not an uncommon scenario that we've both seen.
Yep.
Obviously formally well educated, but they also did not receive formal training or certification for device processing.
Exactly. And that is, you bring up those clinic locations, and you're absolutely right. Health systems are buying up these clinics and different locations all over the place. And then they're left trying to kind of, I don't want to say fix, but raise the level of all these different locations to accreditation standards. And a lot of times they find that they're, they've done things so differently over all these years that they have a lot of work ahead of them. But, John, you and the rest of our team, we've been going around a lot and trying to help people prepare for their accreditation surveys. So I was just wondering if you could share a couple recent examples of the things you've seen while you're out there in the field trying to help these places.
Sure. Yeah. So like I had said earlier, it goes back to the steps of processing not being followed as per IFU and as per their own reference standards and guidelines or policies. So pre-cleaning, I've seen it where for Olympus scopes, the air water channel cleaning adapter is completely not used. It was left in a cabinet or a storage area somewhere. That is a prescribed step of processing that has to be followed. And the only place that can occur is in the procedure room while the scope's still hooked up to the processor. pre-cleaning not consistently occurring, especially for scopes that are routing from, say, an OR setting or a clinic setting, where you'll hear that, well, the scopes that come from GI endo are always pre-cleaned, and I can tell that when I receive the scope. But the scopes may sit for a long period of time that come from an OR setting, or they're left after hours and we find them the next morning, that type of thing. Those
Yep.
are all red flags. So this is something that we've been aware of for years, and it's been a citation for years, but the dilution for detergent used in manual cleaning matters. And we've seen people saying, I use 2 pumps. The next staff member says I use 3 pumps. The next staff member says I use 4 pumps. You ask them how much water they're putting that detergent into. Well, I was taught to fill it up to the top. Well, how many gallons is that? I don't know. I was just taught to fill it up to the top. So you need to make sure your dilution is correct. You also should not be using multiple detergents. As I was mentioning to you recently, Kevin, have seen it more than a few times at sites where the pre-cleaning sponge that already has detergent follows the scope into the processing area. They continue to use that same sponge that has detergent in it, and then they're adding different detergent into the wash water. So you potentially have chemical interference. You have highly concentrated detergent. Leak testing, not performing it as per the IFU, taking enough time, not doing it correctly. Storage of endoscopes, your endoscope cabinets. It's kind of like when company comes over or your mom comes in to check to see if your bedroom's clean when you're a kid. It's the obvious that matters. So the storage cabinet needs to be clean. The scopes need to look clean. There can't be any questions that way. Can't be any contamination risk. So it's not uncommon for people to put all the focus on flexible endoscopes, but other things are commonly processed with especially GI endoscopes, esophageal dilators, for example.
Correct.
And then you see where those are stored, and you find them stored in the processing room in a drawer, or instead of in a separate area under positive pressure, or you find expired dilators. So each and everything that's being processed, not just flexible endoscopes, need to be paid attention to. Again, for the last several years, Joint Commission especially has been very cognizant of whether people are performing hand hygiene and wearing clean gloves when they remove scopes from a cabinet to take to a procedure. And then are they just carrying the scope in midair through the hallway to the procedure room, or are they putting it in a containment like a tray to transport it, that type of thing? And then again, this is nothing new, but it's still occurring over and over and over again. MRC, minimum required concentration, test strips, the documentation related to those, both on the test strip bottle. What's on the test strip bottle needs to match what's on the log. The log needs to be complete. You'll find expired test strip bottles. You find logs that don't match the test strips. It's all over the place. So documentation, I think one of the best opportunities for that from a system perspective is make it somebody's job. If you're a 24/7 operation, make it a per shift job. Somebody, a supervisor, a lead, somebody has the job of double checking the documentation before everybody leaves. If you're Monday through Friday daytime, make it a once a day type of thing where somebody's double checking the paperwork before, because it's a lot easier to troubleshoot this and also have behavior modification if you're doing it closer to when it happened. And it's also easier to correct errors closer to when it happened too. So
yeah, it's always fun trying to correct a documentation error a week later.
Yes,
the person's on vacation and they have
before Joint Commission walks in the door.
Yeah, good luck with that.
Yeah. So, and also this should be very obvious, but physical space, the doors have to remain closed. A processing area needs to be under negative pressure to the surroundings. So if there's a door and it's not closed, there should be a door to begin with, but the door needs to be closed to maintain that negative pressure. Eye wash needs to be available. It shouldn't be at the decontamination sink. The caps on the eye wash should remain on the eye wash itself so that you're protecting the next person that needs to use the eye wash. And then the basic lack of a soiled to clean workflow. If you have processes that are overlapping where you're headed to the right, then you're back to the left, then you're back to the right. It's visually very obvious that this is wrong. So sorry, I guess I kind of went off on a tangent there with all
No, that's
those.
great. But those are real findings in the field that you have been seeing recently. And some of those are ones that we've seen for 10 or 15 years. And some of them are ones that may be more recent. But either way, we got to get better at endoscope processing. And that's why I brought you on here to share all of that recent experience and the wealth of knowledge that you have in this area. So, John, I really appreciate you coming on the show. I really think that we were able to highlight a lot of those areas where people could try and correct these things ahead of time, ahead of their accreditation survey, and get out in front of things and do a lot of even low-hanging fruit type things, like you mentioned with the doors and the workflow of going dirty to clean and all of that. Those are somewhat obvious things, but if they sit back and actually watch the process, maybe they'll be able to identify those issues ahead of time and get it corrected in time. So thanks a lot. I really appreciate your help on this one, John.
You're welcome, Kevin. I just have one final comment, and that would be that it's within everybody, every individual staff member's responsibility and control to change how we approach this. So years ago, as we both know in healthcare, it was not uncommon that you hit all the bad things when an external surveyor came in. Fortunately, we're shifting now in the direction over the years of ongoing readiness. So make it part of your daily routine, make it part of a periodic routine where we self-survey to make sure, let's not wait for somebody external to come in and tell us we're doing something wrong. Let's monitor it on an ongoing basis. So
absolutely.
Thanks, Kevin, very much for having me today. I appreciate it.
That wraps up our interview with John Whelan. Just to recap, we talked about survey readiness for flexible endoscope processing. John shared with us how surveyors use internal policies and procedures, as well as industry standards and manufacturers' instructions for use as their sources for expected practices. There's also been an increase in attention given to the active drying of endoscope external and internal surfaces. And lastly, John shared many examples of common potential sightings by surveyors that he's been witnessing lately in the field. I hope this episode was helpful for you in preparing for your next accreditation survey in the endoscope processing arenas. If you need any help with any products for your endoscopes, don't forget to check out healthmarkgi.com, and please remember to subscribe to the podcast, and thank you for listening. All opinions expressed on this show are those of the presenters. Before using any medical device, it is important to review the device manufacturer's instructions for use. Instructions for use. Instructions for use.